This lecture is about the functional and applied anatomy of the stomach. The aims of this lecture, first of all, to study the structure and function of the stomach. Secondly, to know the blood supply and nerve supply and lymphatic drainage of the stomach. Finally, to correlate the clinical problems. General anatomy of the stomach. It is J-shaped organ, consists of two surfaces, anterior and posterior, two curvatures, cardiac and pyloric, two curvatures, lesser curvature and greater curvature, two orifices, cardiac and pyloric. It lies in the epigastric, umbilical, and left hypochondrial abdominal regions. The size and position is variable, or size and position are variable, depends on the body shape, degree of distension and posture. Relations of the stomach. We have anterior relation and posterior relation. Anterior relation, anteriorly the stomach is related to the liver and to the anterior abdominal wall, the diaphragm, costophrenic angle, within the pleura, left pleura, left lung. Posterior relation can be seen in this picture because of the shadow of the posterior structures. Posterior relation, the same as anterior, like the diaphragm, because the diaphragm is covering anterior and posteriorly. So the diaphragm, the left pleura, the left lung, the spleen, pancreas, splenic artery, and the left kidney. So all these structures collectively is called stomach bed. The stomach wall consists of the outer layer, which is the serosa, or what's called peritoneum. Then the muscular layer, which arranged in three directions: oblique, longitudinal, oblique, and circular. Gastric mucosal, and finally, of course, the inner layer, or it is the gastric mucosal surface, which lined by tall columnar mucus secreting epithelium and studded with gastric pits, each being the opening of gastric glands. The structure of the gastric mucosa variable. In the cardiac region, it's mainly mucus secreting. In the body, acid secreting oxyntic and chief cells. In the pyloric antrum, it's mainly mucus secreting and cell secreting gastrin, which are called G cells. This is showing a mucosa, the cells within the mucosal with gastric mucosa. The cells, different types of the cells, which arranged within the gastric mucosa. At the pit, mostly the surface mucus cells. At the isthmus of the gastric glands, oxyntic cells or parietal cells. At the neck, it is mostly mucus secreting cells. At the base, there are chief cells and enteroendocrine cells. Blood supply of the stomach includes arterial supply. The blood supply it is taken from the celiac trunk, which is short, and it divides into three arteries, into three branches: left gastric, splenic artery, and common hepatic, which continue as hepatic artery and gives a branch which is gastroduodenal artery behind the first part of the duodenum. The left gastric artery runs towards the esophagus, esophagogastric junction, and turns in them down, lower down in the lesser curvature, in the lesser omentum, anastomosing with them branch from hepatic artery, which is called right gastric artery. On the left, on the greater curvature, we have a branch from splenic artery, which is called left gastroepiploic artery, and a branch from gastroduodenal artery from the right, so it is called right gastroepiploic artery, anastomosing on the greater curvature. Another branches from the splenic artery that supplies the fundus, called short gastric arteries. Again, this is the celiac trunk, showing the branches: splenic, right, left gastric, and hepatic artery, and their branches. Dissecting the celiac trunk, of course, should remove the require removal of part of the left lobe of the liver, and also in order to reach to the area between the stomach and the liver. Here, this picture shows the stomach in position with this is the stomach. This is the stomach. This is the lesser curvature, and this is the greater curvature. Of course, the gastroepiploic vessels run on the lesser, the greater curvature. This is the attachments of the omentum, lesser omentum to the lesser curvature, and this is the greater omentum to the greater curvature. This picture shows the right and left gastric arteries on the lesser curvature. These are branches from them. Branches from the left is branch from directly from the celiac trunk, and the right gastric artery from the hepatic artery. This picture shows the splenic artery. Of course, this is situated in the upper margin of the pancreas. Upper margin of the pancreas. So after you can see this after removal of the stomach, as well as the exploring the bed of the stomach. The blood supply this here showing again the blood supply from the celiac artery or celiac trunk, which supplies the spleen and the stomach as well as the duodenum. This is the superior mesenteric, which supplies the other part of the GIT, and this is the inferior mesenteric artery. So generally showing the arrangement of the vessels or the arteries from the aorta that supplies the gastrointestinal tract below the esophagus until the anal canal. This is again the splenic artery, and this is the splenic vein, which is situated behind the pancreas, forming the portal vein. This is the portal. This is the splenic vein. This is the superior mesenteric vein, and this is the inferior mesenteric vein. Collectively, they form what's called portal vein. So this is the portal vein, and this is the hepatic artery, and this is the bile duct. These three structures, situated within the free margin of the lesser omentum, forming what is called the epiploic foramina. So in the free margin of the epiploic foramina. Venous drainage, these run with the arteries. So they drain all of them to the portal vein. The short gastric vein drain with the left gastroepiploic, or what's called gastroomental vein, to the splenic. Right gastroepiploic, it drain into the portal vein. Right and left gastric veins drain also to the portal vein. But one important thing here, the site of what's called here at the lower esophagus, between the veins of the portal vein, this is of the inferior gastric, and the azygous vein, which is systemic vein. So this is an important site for the portosystemic anastomosis. Lymphatic drainage of the stomach. Lymphatic drainage accompany blood vessels. All eventually drain into the celiac nodes. This lymphatic drainage of the stomach is extensive and complex, creates problems in dealing with gastric cancer. Involvement of the nodes around the celiac trunk may render growth incurable. Retrograde spread may occur into the hepatic nodes at the porta hepatis. Enlargement may cause compression of the bile ducts to cause obstructive jaundice. So I have four main groups of lymph nodes which run with the arteries. This group, of course, all these lymph nodes distributed along the greater curvature, the arteries of the greater curvature, and also of the lesser curvature, which are the right and left gastric arteries and right and left gastroepiploic arteries. They drain into the splenic veins, splenic lymph nodes, and eventually they drained to the celiac lymph nodes. Nerve supply of the stomach, of course, autonomic nerve supply consists of sympathetic and parasympathetic. The sympathetic nerve supply from the sympathetic plexus. Sympathetic plexus on either side. This is sympathetic plexus on either side. The sympathetic plexus, the right and left sympathetic plexus. The nerve arises from via the greater splanchnic nerve to the celiac plexus. This is celiac plexus around the celiac trunk through the greater splanchnic nerve. Greater splanchnic nerve. Parasympathetic nerve supply is through anterior and posterior vagal trunks. Stomach nerve supply through the vagus. The left and right vagus nerves enter the abdomen through the esophageal hiatus at level T10. Relation of the stomach and growth of the stomach explain why the left vagus nerve becomes the anterior vagus and the right vagus nerve the posterior. This is because of the rotation during embryological development of the gut. The anterior vagus supplies the anterior surface of the stomach and gives off the hepatic branch via liver, gallbladder, to the liver, to the gallbladder, and the pylorus. The posterior vagus gives off a celiac branch which passes to the celiac plexus and posterior branch to the posterior surface of the stomach. The understanding of the role of the vagus in surgery for bleeding peptic ulcers. Knowledge of the anatomy of the esophageal hiatus and important relations necessary to avoid injuries. Vagus is responsible for gastric motility and control of gastric secretion. So vagotomy, which is the operation done to cut the vagus nerve, so innervation by vagus nerve to decrease the acid secretion, affects motility and reduces acid secretion. Difficulty in emptying the stomach through the pylorus. So proximal selective vagotomy is the alternative. Maintains the innervation, which is called nerve of lethargy of the pyloric antrum, and hence it is propulsive activity to allow stomach contents to pass through the pylorus is maintained. Total vagotomy, which is also called truncal vagotomy, is accompanied by some form of drainage procedure, which is either pyloroplasty to render the pyloric sphincter incompetent, or gastrojejunostomy, draining stomach content into the small intestine, the jejunum, to bypass the pyloric sphincter. This is because of the slow drainage after vagotomy, movement decreased or sluggish of the stomach. So the emptying of the stomach is difficult. In order to enhance drainage, so do either pyloroplasty or gastrojejunostomy. These are pictures through the endoscopy, or it's called gastroscopy, showing gastric inner part of the stomach. Of course, you can see here the gastric cardium. This is the cardium. Here the gastric fundus. Here the fundus. This is the cardiac orifice. These are, you can see the rugae within the gastric body. A gastric body also showing the normal mucosa. Again, the rugae and the gastric antrum, and this is the pyloric opening. So this is the pylorus or the pyloric canal. Now we'll come to the clinical applications. One of the problems that happen in the stomach is called gastric ulcers. Gastric mucosa, of course, definition of the ulcer is the breakdown of the epithelium. So gastric ulcers, gastric mucosa, which happens within the mucosa. Gastric mucosa is the site of gastric ulcers. Can occur anywhere, but are commonly found on the lesser curvature. This disorder cause epigastric pain. Patient with gastric ulcer can complain pain on eating, while those with duodenal ulcer complain of pain when they are hungry. Indigestion, which is often associated with pain. Indigestion, there is some difficulties with food taking. So there is pain, heartburn from acid peptic reflux is common. Anatomical relations determine that posterior wall ulcers penetrate the region of the splenic artery and thus bleed. Anterior wall ulcers penetrate the peritoneum and thus perforate into the peritoneal cavity. This is in comparison with the duodenal ulcer. In relation to duodenal ulcer, anterior ulcers also similar to that of the stomach perforate, and posterior one penetrate, so also causing bleeding. These are some this is the radiological study for the stomach, showing this is what's called barium. This is what's called barium meal. This is the barium meal, and going through the small intestines, called studying the intestine through this barium. It's called barium follow through. So you can see here the stomach. It is almost J shape. You can see the lesser curvature, the greater curvature, and also air in the fundus. Usually air in the fundus. Rupture may lead to escape of this air, so located under the diaphragm. So it's an important sign in the perforation of the stomach or any part in the gut or intestine may lead to the escape of the air, and it is located under the diaphragm. Posterior gastric cancer or ulcer may erode the pancreas. Erosion of the pancreas, because the pancreas is here behind the stomach, so leading to back pain, and sometimes, of course, erosion of the splenic artery may lead to severe bleeding. Ulceration into the splenic artery may result in severe hemorrhage. And thank you very much.